Hello everyone, I'm Dr. Lalit Maini, Editor-in-Chief of Indian Orthopedic Association. I'm going to talk about evidence-based orthopedics. This is a talk on behalf of the editorial board of Indian Journal of Orthopedics, and Dr. Srinivas Kambapati, the associate editor of the journal, has immensely contributed towards this talk. So definitely we are interested in the definition of evidence-based medicine, and it is the conscientious, explicit, judicious, and reasonable use of modern best evidence in making decisions about the care of individual patients. So we need to understand that there are three basic pillars of EBM: the evidence, the patient, what the patient wants, the clinician, the clinical expertise, what the clinician knows, and what literature says about the particular condition we're handling. So when all these three combine together, it brings about evidence-based medicine for a particular scenario. So let's look into each term which we have used in the definition. Conscientious, meaning wishing to do one's work or duty well and thoroughly, relating to a person's conscience. The surgeon is a person in this. Explicit, meaning stated clearly and in detail, leaving no room for confusion or doubt. Judicious, meaning having, showing, or done with good judgment or sense. And all this needs to be reasonable, having sound judgment, fair and sensible, as much as is appropriate for a particular scenario. It needs to be modern, relating to the present or recent times, as opposed to a remote past. And evidence as such is the available body of facts or information indicating whether a belief or proposition is true or valid. And all these apply to the individual, the patient, who could be a single patient, or it could be a disease scenario which applies to the multiple patients you treat. So the first few things are related to the surgeon's clinical expertise, and the others are about what is there in literature and what the patient seeks. So is evidence equal to knowledge? So core knowledge you tend to find in textbooks, you tend to see in older established EM write-ups. You listen to them in didactic lectures, you get to know in graduation studies. In evidence-based medicine, you get to look at in journals, various type of search engines, various guidelines. And knocking on all these is logic and intuitive based practice, which actually comes from experience and logical reasoning. So to bring all these type of, you can say, evidence, oblique knowledge, oblique medicine, which the clinician practices, there is a subtle difference in one from the other. So logic or intuitional based practice, there is still no evidence found for it because it happens occasionally. Emergencies where evidence cannot be searched is a key place where this takes its role. And intraoperative decisions for surgeons like us, where we need to innovate and apply our basic knowledge and deal with really new or rare occurrences which happen due to our own logic and our own intuition. So let's look at the advantages of EBM itself. It's backed by solid evidence to practice. It should be leading to better results, increase knowledge and skills of the surgeon. Medical legally, it would help in covering up, increases confidence in the surgeon, patient satisfaction and confidence in the treating surgeon. It does have disadvantages. Creating the evidence-based medicine, the evidence itself is time consuming, as we had seen in the COVID era, in which there was such a big wait for why, what, when, and how for this disease. It's still going on. It needs updating constantly. Again, the pandemic has taught us that every drug came and went. Evidence may change in future, especially uncertain issues. And at times it might take you too far away from the reality of the patient. Local evidence is always better. Some international evidence may not apply to local practice itself. Reasons could be any or many. And standardization for patient and the morals associated is an issue. So if we go back to the history of evidence-based medicine, medicine started as opinion-based. Most of the findings were accidental, and then they became practices. However, gradually they got structure. The most famous one is the clinical trial on scurvy and smallpox, and then came in the RCTs on tuberculosis and the largest clinical trial on the Salk vaccine in polio. So gradually, the system of building evidence and learning from evidence and applying into clinical practice came in. In 1990, Professor Gordon Guyatt coined the term evidence-based medicine. And then it gradually moved into orthopedic practice when JBGS introduced the new section of evidence-based orthopedics in year 2000. And JBGS published the level of evidence in 2003. So these were the building blocks of the ultimate evidence-based medicine, where you need to actually define the level of evidence of each literature that is published. And as after that, the story continues. So as I told you, the pyramid of studies based on level of evidence form the basis and the building block of evidence-based medicine. The weakest evidence is of expert opinion, case reports, and retrospective studies, which are observational. Then come in the experimental studies, which are controlled clinical studies or RCTs. And the highest, strongest evidence is from study level data, the systematic review, and the top of the triangle, the red one, the clinical practice guidelines, which are actually the evidence-based medicine. So if you see the lowest part, why the level of evidence is low is that there's actually no design. So that's why whatever comes out of it might not be a very robust thing. And the middle part is are the primary studies, which actually bring out experimental or non-experimental work and creates knowledge. The knowledge coming out of these studies get converted into secondary evidence, which are meta-analysis and clinical practice guidelines, which help you in deciding upon what a clinician should do. So if you broadly understand the type of study design in medicine, it will be basic studies, observational, experimental, economic evaluations, and meta-analysis. And the two in the red block are the most important for authors as well as healers. This is where the evidence starts and gets generated. Let me take back you guys to what an author or a reader is looking at when you are looking at evidence in a journal or medical literature. 70% of the literature is observational and experimental work, which we just mentioned. They're actually, we are looking at cause and effect. It could be of disease, it could be of a therapy, and that is where it helps in getting the treatment protocols in place. 20% would be reviews, which could be narrative, which are invited, systematic reviews, which are invariably from area experts, and meta-analysis, which actually come out of Apex Institute. The 10%, the very small contribution in literature is from letters and other type of literature like images, commentary, grand round, and book reviews, editorials, which could be traditional to current issues. And these are the ones which are actually eminent eminence-based. And this is where you have uncontrolled, uncontrolled sort of literature, which might not be backed by a systematic research design, but they have their own importance because this is where the intuitive type of medicine comes in, the logic comes in, the experience comes in. So how to do evidence-based orthopedics? Uh, it has an algorithm. You need to have a clinical scenario or a question. You acquire the best evidence by going through literature. You appraise the evidence. That is, you critically evaluate what you have gathered, the best evidence, and then apply that evidence to a patient and assess your patient whether how it has helped the patient. So this is the cycle or the 5 A's of how you go about using or applying evidence-based orthopedics. Where to find it? It is there in clinical practice guidelines, health technology appraisals, various other platforms like NICE, Sign, AOS, Ortho Evidence, Cochrane Library, and of course, systematic reviews and meta-analysis. So Ortho Evidence is one of the current popular platforms where you get evidence-based orthopedic content. It was formed somewhere around 2009 in McMaster University, Canada, and Dr. Mohit Bhandari, a famous researcher, has been instrumental in getting this out. It talks about various problems which are burning and the various facts associated with them. NICE is the National Institute for Health and Care Excellence from NHS, and it focuses on improving health and social care through evidence-based guidance. The guidance coming out of this is very, very specific and clear, and you can use it in your clinical practice. The Scottish Intercollegiate Guidelines Network, the SIGN network, is the Scottish guideline. Again, it will give you specific answer to specific scenarios. The American Academy AOS guidance is the most popular and it's the most evolved. It also has various type of rating scales of the evidence which you're looking at to help you critically appraise them. Like you have a 9-point appropriateness scale, which would classify the literature from appropriate to rarely appropriate. Like for in this example, interpreting the appropriate use of criteria for the surgical management of osteoarthritis of knee. The top you see the rarely appropriate, maybe appropriate, and then it further goes and defines the numbers under M in the column on the right, the median rating of voting panel. So once these guidelines are set up, they are shared with experts who vote for or against a particular thing, and a plus or a minus symbol comes in if there is agreement or if there is not. The grading system also has a system of definition of high, moderate, low, and very low grading. High means further research is unlikely to change our confidence in the estimate of effect, and very low meaning any estimate of effect is very uncertain. Now, all this categorization helps and is of advantage, ensures these factors are considered appropriately and helps in critically evaluating. TRIP is another database formed in 1997. It's a free access. You can see the full form is turning research into practice. So it gives you evidence-based data. And there are various others. If you Google evidence-based medicine, you will get a list of them, and you can choose the best fitting for you and then apply it to your practice. So evidence-based medicine, is there evidence for it? So this is a very nice systematic review published in 2019, which says that yes, it improves the short-term knowledge and skills, but still there is no evidence on improvement on long-term knowledge, attitudes, and clinical practice. Future of EBM, a principle of medical professionalism, not limited to process of drug and device evaluation, independent of all interest, whether commercial, ideological, or political, allied to but separate from and serving a different function than the original science which is published. And if we have to summarize, EBM arose from a need to consolidate evidence in research, good evidence that it improves practice, identify sources of highest quality of evidence, and exercise EBM to improve clinical practice, which will ultimately improve healthcare. So it's a balance between art and science. And once you capture the science, you will realize healing is an art. And once you develop the art, you will see that you missed out on some science. So the cycle of art and science in life goes on to improve healthcare and to have a better planet. Thank you very much for your attention, and I welcome all of you to contribute and also read the Indian Journal of Mathematics. Thank you.